Good afternoon. It's a very sleepy afternoon, but thank you for being here. Usually, CVI sessions are very poorly attended, but at least I can see a few of you here, and I hope that you all are wide awake for this. The reason is that CVI is a condition which is very commonly seen in children of our community, especially in India as well. It's not just the West, but it's just that we need to have the urge to find these cases and treat them, because as Niranjan and Namita have said, that CVI can be very disabling, but is totally trainable, and it is up to us to give the right direction for the parents to train them. So my job is to take you to the next understanding of cerebral visual impairment, high functioning CVI. Now, high functioning CVI is not very, it is not written on the patient's face that this is high functioning CVI. They normally are referred to us ophthalmologists with the diagnosis of learning disability, behavioral disorder, or even intellectual disability. And as you've heard both Niranjan and Namita talk about the fact that CVI is not a single diagnosis. It is a term of visual impairments because of brain damage, and it is not that you have to have low vision to be diagnosed as CVI. You could be 6'6", but still have visual impairment. And the reason I'm saying this is because for me, vision is just not visual acuity. It is much more than that. It helps me to interact, to learn, to mobilize, and to communicate with people. So children with high functioning CVI are children who have good vision, have good visual potential, but have some kind of impairment. Now let me explain that a little more. As we all know, as ophthalmologists, that more than 60% of our brain subserves vision, and it is a highly complex wired connection which helps you to subserve this vision. It's just not visual acuity. And one loose connection in this entire visual, in this connection will give you an experience of a totally different world. And that's exactly what a child with CVI would say: I do not understand what my mind does not, I do not see what my mind does not understand. Because this is ironical. As medical students, we have been told that what the eye does not see, the mind does not know. So you see a sign and you know the diagnosis, but that is not always so. So a CVI child has a different perception of a world, a different understanding of a different world from yours. It is not an abnormal world because nobody certified that we are normal. Let me go ahead. Now, if I show you this picture, all of us are perfectly sighted, but you all have different perceptions to this picture that I'm showing you. Some may say this is a rabbit, some may say there's a duck, some may say it is both. Well, fine. So there's nothing wrong in this perception, but all of us have had different perception of the same picture that is shown to us. And so is also a child with cerebral visual impairment. Now look at this child. He's a 10-year-old boy getting irritated in the outpatients because his mother is talking to me. This is just a 2-minute this thing. He's even kicking his mother. Now this is being a little different in behavior. He was referred to us for behavioral disorder, and it's a little different in behavior because when I prodded a bit more into the history, I found that this child does not go to school, is partially dependent on his parents for activities of daily living, and does not like fast-moving stuff. Look at this child's painting. This is an 8-year-old boy from Bangladesh who has been coming to us for a while. He's a spastic diplegic with about 6/12 vision. And this painting that he has drawn gives me a whole lot of information of the world that he is experiencing, which is different from what I experience. I will apologize for some of the slides that are being used, because these are slides of Professor Dutton, my mentor, and Niranjan has already used them. So, but it is basically, I'm replaying this for you for a better understanding of what cerebral visual impairment would be. So my next then it brings me to the topic of my talk today: how and what do I assess in high functioning CVI? As again in medical education, we have been told the diagnostic tool for a good clinical examination is history taking. It's just spending time talking to the parents that will give you the diagnosis of CVI. 90% of your diagnosis is made based on history taking. Clinical examination will aid your diagnosis, but and if you're lucky enough, if you have access to radiology, then that would be the cherry on the icing. So how do I go about? But before I do that, I will just run across again. We are looking at dorsal stream, which is occipital lobe connecting to the parietal lobes, the ventral stream connecting the occipital lobe to the temporal lobes, and also the subcortical pathway, which is the thalamus hypothalamus connecting to the middle temporal lobe, and thereafter the dorsal stream. Now, first of all, as any examination, ophthalmology begins. Before I do a ophthalmology examination, I always take a good history, and the questions that I normally ask are just a handful of questions for dorsal stream function. That is, how independent is your child in activities of daily living? Does your child attend school? And if it attends school, what are the issues? If not, why does the child not attend school? How does the child behave when he's out with his peers? How does he behave when he is in a marketplace or in a garden or in a park? Is he able to play any outdoor games? How does he behave? And also, what does he do when he's going downstairs? All my questions are very open-ended, and it is not intimidating to the parents. And when I'm asking these questions, I'm keenly observing the child as well in my outpatients to know what, if the parents have said, is actually corroborating with what the child is doing. For ventral stream dysfunction, I have only 3 or 4 questions regarding recognition of familiar faces of the family, of how does the child recognize familiar objects of everyday use, and is the child able to go to a nearby shop or to the next door neighbor's house, and how is he able to manage to come back, or does he always need his or her sibling along with them? So now moving on to the examination part of it. Sorry. I start off with a visual acuity assessment, which will be the lower field, will be the occipital lobe function that we see. And visual acuity is the clarity of image. You can see how the clarity deteriorates as the vision deteriorates. It is also important, as has been told by the previous speakers, that contrast sensitivity is as important as knowing the visual acuity, because if the visual acuity is low and the contrast is good, the child is able to pick up the nose of the teddy bear in this picture. But if it is a low contrast, the entire picture is washed out. And so when we provide strategies for children with CVI, these have to be kept in mind before we actually speak to the parents. Now, the red box is the middle temporal lobe, and this observes motion or movement. Many times children come to us with parents complaining that this child has an abnormal back and forth movement, a rocking movement, or moving of the head from side to side. This is not behavioral. This may not be behavioral disorder, I must say. It could be a part of CVI. This is because the occipital lobe may not be functioning or may be damaged, and so the child does not understand a static world and would like to use movement to understand the world around him. On the other hand, you will have children who would come to you and say, oh, I kick a ball during a football game, but I don't run after it. And why is that so? Because the temporal lobe is damaged. So he does not appreciate movement. He appreciates the static object of the ball standing there once it's kicked and rolled out. There are children who don't like to deal with small not small animals like dogs and cats, because they run suddenly and come into their visual field and they haven't appreciated the movement of those animals. So that is why, and that indicates that probably the middle temporal lobe is affected. Now, moving on to the ventral stream, again, it is it is a stream which helps with recognition, and damage to either of the lobes or both the lobes will impair recognition of face, objects, roots, and shapes. So, if a child with ventral stream dysfunction may be able to recognize Kareena Kapoor's face when it's square on, but when it is a side view, the recognition may be difficult. And ventral stream dysfunctions are usually picked up when you see that the child has actually used his sense of touch, smell, sound to actually recognize people. Many times parents come and say that the child is always touching the table to pick up his pen. Always touch. If you give a child a ball to handle, he will try to feel for it, listen for visual, auditory cues by the parents, and then recognize what that structure is, even though they know it's a ball, even though their vision is 6/6. Now, moving on to the dorsal stream, the parietal lobe is a very important structure of our brain. It not only subserves our visual field, it also helps with us giving importance to the scene in front of us, moving us subconsciously through 3D space, giving attention to element that we want to by stimulating the frontal eye fields, and then ignoring the rest of the scene in front of us. There are many symptoms of, or rather signs of dorsal stream dysfunction. I'll try to explain each of them as I go about. Now, there is the first symptom that I'm going to talk about is impaired attention and not inattention. They are two different things. Impaired attention is nothing but what is known in literature as simultagnosia, where means the child is not able to perform two tasks at the same time. And you would have parents complaining or the child being referred to you because he's a bad child at school. Now, the child may not be a real bad child. It's just the fact that when the teacher is speaking and there's a smart kid sitting next to the child and always answering the child, answering the questions that the teacher is asking, the child is not able to process two things that's happening at the same time. And so immediately goes and nudges and harms the child sitting next to him. There are children who have problems with copying from the blackboard because their visual scene is so complex that they are not able to do writing and copying at the same time. Now, you look at this kid in this video. He is trying to talk to me, but he always moves his eyes away because he does not hear when he's looking at me, and when he's looking at me, he does not hear me. Are you going to play for me? You see that? And 2 seconds of eye contact he makes, and you see how he's so much as discomfort. He immediately lowers his eyes because he does not want to make that eye contact because I'm constantly speaking to him. Visual field assessed is also a part of the parietal lobe dysfunction, and children of high functioning CVI are very smart. They usually learn to overcome their difficulties, and they know and many of them do know that their lower field is affected, so they always tend to give an impression that they're actually seeing by hinting with their hands that they are seeing something. But I insist that the child, if I am showing an object in the lower field, I insist the child either point to the object of regard or touches the object of regard. You can see this kid here, the same kid that we saw earlier. It seems that he's seen that object, but he's not. There you go. And see how he's fatigued. He doesn't want to carry it because CVI can be quite a tiring job for children who are affected with it. I'll go back to this picture that I showed you before. If you look closely at this picture, this child has a right inattention. If you look at it, the child's right side of many of his figures are not in good detail. There are some of them which he has done because he's been always told to pay attention to the right side, and so he gives attention but only on being giving the cues for looking at the right side, but otherwise he actually doesn't pay attention to the right side. The other smart thing that he's done is, other thing that I understood from his picture is that he sees his world tilted. Okay, and the moment he has to show me something, he knows that he has to raise his right side up, and that's what he's doing in the second picture, so that I see the picture straight on and I don't see it tilted. So I think this is his diplegic which is causing him the problem, but it's actually not the diaplegia which is causing him the problem. I mean the physical, the motor part of it. It is the world of tilt that he experiences, and that's how he draws it. Okay, so it is good to know all these things, because your habilitation for these children, I did not use the word rehabilitation, but habilitation for these children have to be directed in that way. Now, as I said, parietal lobes help you to move through 3D space. So when the visual cortex sees an object, it makes your parietal lobes stimulate the motor cortex, and you go out to reach that object of regard. Now what happens is, when there is an impairment in this function of the dorsal stream, the construct of the object in your brain is not well formed. So everything is related to my brain is using in the visual space is with my body. And if the object of regard is far away from my body, I do not actually know how to relate to it. So you will have children, parents coming and saying, oh, everything which is lying on the floor, he bumps into it. So there are two things you can infer out of it. Either that he has a lower field defect, or he has a visual impairment of guidance of movement of the lower limbs, or which we also call as optic ataxia of the lower limbs. There are children who will, when asked how do they replace things back, they say they throw it, or they keep it in such a way that's at the edge of the table. That is because when they are looking at something to be replaced, all they see is the table as long as this. They do not know where it starts. So the moment their hand goes, it just goes where their hand will lead them. And that is called optic ataxia of the upper limbs, and that's how the tendency for it to fall, of the objects to fall, happen. Now the next two videos I'm going to show that. You see that this child, how do you play that? Sorry. Okay, so you see that this child has seen everything that's lying on the floor, so he does not have a lower field effect, but he bumps into things which are low lying, and because that object of regard is not in his visual space, is not related to his body. There you go. He again looks at it that way. Whereas if you look at this child, you see her that as soon as she saw the torch, there is a mid-fanning of fingers to reach the torch, and the moment the fingers touch the torch, the hands close in to pick up the torch. There you go. Okay, so there is an optic ataxia of the upper limb as well. Now, after the motor cortex is stimulated, it is the role of the eyes to pay attention to the object of regard. And when this part of the dorsal stream is impaired, there is a psychic paralysis of gaze, and not, or what we also call as apraxia of gaze, and not oculomotor apraxia. There are two different identities. In apraxia of gaze or psychic paralysis of gaze, the ocular motility is full and saccades are complete. And so these children, when they're given a peripheral object to hold, they actually do not move their eyes to see it, because they have a psychic paralysis, and it's only their limbs which go and pick up the object of regard. Can we play this, please? Okay. You see, he's been asked to pick up the torch. He doesn't move his eyes, but goes and picks up the torch even without looking at it. But his ocular motility and saccades are full. And then that brings us to the radiology bit of it. You can see the child who had lower field defects. He has the occipital lobe gliosis, ventricular dilatation, parietal lobe gliosis, and he also has thin corpus callosum. That means his dorsal stream is affected. So he has all the symptoms of dorsal stream, that is simultagnosia, lower field defect, and also he has optic ataxia of upper limbs as well. Now that brings me to the last part of my talk. How do we approach children with cerebral visual impairment? As it's been emphasized that children with cerebral visual impairment, whether low functioning or, severe CVI or high functioning, have to have a multidisciplinary approach. It has to be a holistic approach for proper strategies and habilitation for these children to lead a better life. So my team is involves the pediatric neurologists, the development pediatricians, the orthopods, the ophthalmologists, the general pediatricians, radiologists, and the child psychiatrists, and including the rehab specialists as well. So the normal principles, or some of the principles that I offer to the parents in terms of dorsal stream dysfunction is there has to be less clutter, especially children who have lower field defect or visual impairment of legs, that they should avoid having low-lying objects, and they should make the child have get trained into looking down every time the child comes across an obstacle. So when he is out on the road walking with you, when there is a tree or an electric pole or a cyclist coming in front of you, they tell the child there is a cyclist coming. The child has to stop, look at it, and then carry on with the walking that he does. Now the problem with this is it is a little, it requires a little hard work. But if you keep insisting the patients, and if you demonstrate to the patient or the parents that actually these deficits are trainable, the parents are very proactive, and they are interested in bringing about a difference to their children's life. Also, if there's a hemi field, you use some kind of highlighters so that the child looks towards the, gives regard to the hemi field area and avoids bumping into doors and windows. If the child has a visual impairment, optic ataxia of the lower limbs, instead of holding the hand and walking, it is a good advice to hold the elbow or the back pocket, because when you move and there's a change in the difference of the height on the ground on which you're moving, the child can perceive that because your limb makes a difference, and the child will understand that there is a difference in height, and so has to make modifications when they are walking. Training the child to use a body part to keep the object back in the correct place will help the child to be trained, and also prevent a lot of embarrassments. Reading material with children with lower field defects can be asked to use inclined tables, which will help them then use the reading material and access the lower portion of their books, and also use sliders or typographs, which will bring down the clutter of the information on their books and give them only what they have to read, and block off the other parts of the notes or the textbooks that they are trying to read. In ventral stream dysfunction, as Namita has said, many of these children have used sense of touch, smell, sound, and taste, and many children you would see that they kind of smell everything you give it to them. Some of them even lick. I have children who are licking my slit lamp just to know what it is, and I don't think there's harm. Of course, slit lamp has a lot of muck on it, but you can encourage such additional use of sensory system for the development of the child, for the betterment of the child. It's always good when child has ventral stream dysfunction to come close, so the child is able to understand your voice, maybe even use smell to recognize who you are, to use highlights, to use colors, to inform the child that, look, I am wearing this color dress today, and when I go out, and you are out in the public, look for this color dress, and you know that your mother is standing there. So these are some of the strategies that you can offer your children, offer the children for better habilitation for them. So that brings me to the last slide of my presentation, that CVI can be subtle but very disabling, and it is the responsibility of each of us as medical fraternities, as children, as parents, as caregivers, that we make the life of these children better. And for this, we have to change our attitude. It is not that your eyes are fine but your brain is gone. It is not that the child is having a behavioral disorder or intellectual disability or learning disability. It is that the child probably has a CVI, and for that a good history taking will clinch the diagnosis. And we need to create more awareness and education among ourselves and the NGOs and everybody concerned with the betterment of these children, to support these children so that they have better lives ahead. I thank all my patients for teaching me more about vision, and also my mentor, Professor Dutton, for actually training me for this. Thank you.